Dr. Nail Jan for participation in our Congress.
Well, thank you, Adele. You don't know we're about to do this, but as I was saying, we're open here from Boston for the conference and at our meeting in December. Professor, would you join me? At our meeting in December, we wanted somehow to say thank you to you for welcoming us at your conference each of the last 2 years. So we wish to invite you to be an honorary member of Boston from now on, complimentary on us, and that's for you. So thank you to my friend as well. Thank you.
Thank you, Nail. Thank you very much. Okay.
Okay. Shall we start? Dr. Adel. And now back to the knee. The first speaker will be Professor Robert Hunter, who will speak about meniscus pathology and strategies for management. Please.
Thank you. We're going to go back to the knee, and this may seem a little bit fundamental, but I'll tell you this. If you take care of the meniscus and do it well and properly, you'll save more knees than anything else that you do, whether it's ligament or articular cartilage. The thing you're going to see the most often is the meniscus, and if we care for it carefully, we'll do a lot of good for a lot of people. These are my conflicts. The first report that I can find in the English-speaking literature about a meniscus repair is from 1883 from England. And this was a single patient report, somebody who had been sore for about 10 months and reported great swelling. And with medial joint line pain, they were treated with rest, blistering, interesting, topical iodine and liniments, and those didn't seem to help, which is surprising, really, isn't it? When they opened this patient, they found that there was a displaced medial meniscus tear that they reduced, and they sewed together with catgut suture, 3 catgut sutures. Then they put the patient in a splint for 7 weeks. And the follow-up here was an additional 5 weeks. So this is a single case report with exactly 2 months follow-up, which is even short for orthopedists, but they got it published. And they reported that everything went fine, everything was good. So that's the first meniscus repair that I can find for you in the English literature. The meniscus serves a lot of functions, we know, but the principal function is load bearing and load sharing across the knee. And if you look at this study looking at a totally normal meniscus versus a partial meniscectomy versus a more aggressive meniscectomy versus a wedge resection versus a total meniscectomy, which you can see is that there's a progressive increase in the load across the joint. Even with the slightest amount of meniscus removed, the joint sees more pressure across the joint until in letter E, you can see a very, very overloaded joint with no meniscus tissue at all. In the United States, the most commonly coded procedure in the United States is arthroscopic meniscectomy. That's number 1 for all procedures. And if you look at the literature, the the most recent that I could find is that there are about 1 million meniscal procedures done in the United States a year. And unfortunately, only about 10% of those are repairs, which means we're still doing about 900,000 meniscectomies a year. So perhaps we can get better about saving some of those menisci. If we think about managing the meniscus, there are 4 variables we have to deal with: morphology, location, size, and the patient. From a morphologic perspective, the tear that we're most likely to want to repair is this clean, vertical, longitudinal tear that we see inside the knee. So a situation like this, where you can see the meniscus, is this the pointer? I don't think I have a pointer here. Where you can see the meniscus probe pulling the meniscus body away from the rim. That's a nice clean meniscus tear. Or this situation where you can see the undersurface of the meniscus herniating when you use the probe. This constitutes an unstable situation, and this meniscus also needs to be repaired. Which one? Is it working now? I have trouble with Egyptian electronics. Maybe I need to be left-handed. No, it's a USB-C. Yeah. That's okay. That's okay. I can point with a long finger. On the other hand, those tears are pretty straightforward, but look at this tear. Look at this radial tear in this 18-year-old wrestler. And you can see that this is a very damaged meniscus, but if you do a meniscectomy on this 18-year-old, you're taking basically his entire lateral meniscus, and you're dooming this knee to failure over time. So in situations like that, the question is, can it be repaired? And the answer is yes, it can. Radial tears of the meniscus actually heal, and they heal quite well. In this study from Choi, he did MRIs and second look analyses of his knees, which is pretty thorough, and he found that they were partially healed in about half. They were healed fully in about a third. So attempting a lateral or a radial tear of a meniscus is actually a good idea, and most of them will heal at least partially, which is good for the biomechanics of the knee. And the reason we talk about meniscus healing and location is because of the blood supplies. We're all aware. The outer portion of the meniscus quite vascular, the inner portion of the meniscus very avascular, and where along that meniscus the tear is determining how we might think about fixing it, but I'm going to challenge that notion in a minute. Size is also an issue. Tears that are less than a centimeter are typically stable. If they're more than a centimeter in length, they become unstable as you probe them, and those become menisci to repair. So the ones that I will leave alone are these, the ones that are acute, that are small, not large enough to be unstable, therefore stable, and in a red zone or very peripheral. They'll heal if you leave them alone, and I don't think there's much we have to do there. The ideal tear to fix is a vertical tear. That's chronic, that's clean, in the red zone, and large enough to be unstable, a centimeter or more, and that becomes an ideal meniscus to repair. But look at this. This is a very complex tear on the lateral meniscus, and if I play this, you'll see there's a large, unstable flap of meniscus. You see the popliteus tendon there. This is a doomed knee if you do the meniscectomy. And so an effort was made here to repair the meniscus using some proprietary instrumentation and to just grab whatever was possible to try to suture it back and create a rim. And looking back 8 months later, you can see that the meniscus volume has been restored pretty well. Is it normal? No. But is that a better meniscus than a total meniscectomy would have been? I would argue yes. This is an effective way potentially to deal with these complex tears. Here's another example. Look at this horizontal cleavage tear, something we would typically remove with an unstable flap underneath. But if you're careful with this and prepare it, you can actually repair these now using, again, proprietary instrumentation to suture these together. You have to place quite a few sutures here to close this tightly so that it doesn't get any synovial fluid in it, as you see here. But again, looking back 5 months later, what you can see is this meniscus has healed. Is it a normal appearing meniscus? No, it is not. But is this better than doing a subtotal meniscectomy for that horizontal cleavage tear? Yes, it is. And this is a good thing to do in a younger, non-degenerated horizontal cleavage tear. The question becomes, do these heal? And the answer is, oops, I'm sorry, I'm going to back up here. Can I back up? Maybe not. I was going to show you the data with these horizontal cleavage tears, and the fact is they do heal. When Kurzweil looked these up and did a review of the literature, he found that there's about a 75% increase. See, it's not just me. It's frozen. It's not moving at all. Can we back up now just a bit? Go the other way. Oop, back up. Back up. There we go. Thank you. It takes a village, as we say. You can see that the success rate with horizontal cleavage tear repair is actually quite good, almost an 80% healing rate looking at all the literature. So it's clearly a tear to try to repair in a younger population. And then what I call, quote, young. What's the difference between a young meniscus tear and an older meniscus tear? I think this is like fractures. A young tear, a tear in a younger person is an acute injury, like an acute fracture. As we age and our menisci are damaged repetitively over the years, when it finally fails, it's like a repetitive microfracture. It's like a stress fracture that finally breaks up. And how you fix those two will obviously vary. So in that acute clean tear, fix it. If it's a degenerated, worn, badly damaged meniscus, there's not much sense in trying to put that back together again. So age matters a little bit. So I would like to share with you now my approach to meniscus as of 2020. Number one, and the most important thing for me, is to get a view. If you can't see what you're doing, you're going to do imprecise work, but more importantly, you're going to damage the femoral condyle as you try to gain access to the back of the knee. So getting a view is important, and I have a very low threshold for doing a medial collateral ligament relaxing procedure, as I'll show here. This is a knee that's tight, and then I'm pushing as hard as I can. I'm putting valgus across this knee, and I really can't see that back portion of the knee. Now this looks degenerated, but I still can't see it very well. And in those circumstances, I will use an 18-gauge spinal needle to relax the medial collateral ligament. I find the joint line, as you see there, and I'll move up about a centimeter and a half from the joint line, find the origin of the MCL, and with valgus stress, I will poke the medial collateral ligament up probably about 10 times until I feel the ligament give way. And when it gives way, it's quite dramatic, and you dramatically improve your view. So here, I'm finding the joint line with my spinal needle, and then I'm moving proximal about a centimeter and a half, and I begin to poke on the medial collateral ligament, and as I do, you'll see as I release, and all of a sudden it gives way, and now I've got a great view of the back of the knee joint. Now this is clearly a meniscectomy patient, but in a meniscus repair, this works very, very well to gain access and a good view so you can do your work and not damage the condyle. My approach in the posterior 1/3 is an all-inside approach using fourth generation all-suture material. There are lots of options available in the literature and on the market now. The one that I'm most inclined to use now is this instrumentation that delivers an all-suture fixation technique, so there's no peak anchors, there's no plastic, there's nothing in the joint except suture, and I like this very much, and it works very well in my hands. This is an example of a quick video showing such a repair. And you can see this is a displaced bucket handle tear of the medial meniscus. And once reduced, you can see that it really sits very nicely in the joint. We go to the posterior medial corner to try to anchor it there so that we take some of the mobility away. And in this case, I didn't feel I could get a vertical mattress in comfortably, so I did a horizontal mattress. And I think a horizontal mattress repair is perfectly acceptable as long as you go above and below the meniscus and try to anchor it on top and on the bottom, as I'll show in this video. I take a gap of about 5 millimeters, and then I pull it tight. Be careful not to pull too tight, because this can cut the meniscus. The suture is very able to cut the meniscus like a cheese cutter if you're too aggressive. And then I'll repeat the process below, so we'll go above, below, as we need to suture the meniscus and really fixate it completely. And this gives us a good opportunity to repair it back to the bed very nicely. About a 5 millimeter gap there, as you can see. Then we're going to tighten it carefully, not too tight. There you go, just till we get it, the slack out of the suture, and then cut. And you can see there's bleeding back there. I've prepared the rim so that we don't have, so we have as vascular a bed as possible. All inside works well in this study. It looked at all inside versus inside out, and there was really no difference in the biomechanical behavior of these two constructs. So I'm very comfortable with the all inside technique. In the mid-third, my technique is inside out. Oop, I'm frozen again here, let's see. What did we do? What did we do to unfreeze that? Can some, oh, there we go. It unfroze. So I'll use either this proprietary instrumentation for my mid-third menisci. This is zone-specific instrumentation. It's reusable and therefore quite inexpensive. Doggone it. Or you can use this instrumentation, same thing, different company. I don't think you need this many sutures. This was an exercise. We don't want anybody to die of suture toxicity, so that's a bit much. In the anterior third, I use an outside-in technique that I've worked on. It's easy, it's quick, it's inexpensive, and it works. You don't need much equipment to do this and do it well. As you can see here, it's a 5.5 cannula, spinal needles, 3.0 wire, PDS suture, Ethibond suture, things you have in your operating room already, and it makes this a very doable procedure without much expense. So I'm showing you this in a cadaveric model. I'm looking from the anterolateral portal, and I'm working in the medial. There's my cannula in my anteromedial portal. I'm going to pass a spinal needle through the meniscus, as you'll see here, just percutaneously. I penetrate the meniscus, and once I've penetrated the meniscus, I'll pass down the barrel of the needle an 18 gauge, a 3.0 wire that I've pinched real tight. It fits down an 18 gauge needle very easily. This is just 3.0 wire. It's in most operating rooms. Now I'm going to grasp that through my cannula, and once I have a good grip on it, I'll pull my spinal needle out so I don't lacerate anything. I'm going to pull the needle out, and I'm going to withdraw that through the cannula. The nice thing about this technique is you're doing all your work outside the knee, so you don't have to be a hero about tying knots inside the joint. Here's my second spinal needle introduced. In this case, I'll do a vertical mattress, same as before. I'm removing the cannula now, and I'm going to pass a PDS suture. Once I've passed the PDS suture, I'm going to go back through my cannula, and I'm going to grasp that PDS suture, and I'm going to withdraw that through my cannula. I'm going to pull my needle out so I don't lacerate. Out goes my PDS suture, and then the PDS suture is passed through the wire outside the knee, and then you just draw the wire back through the knee and bring the PDS suture with it. And this provides you with a nice, easy way to pass a suture without any difficulty at all. Now, if you want a permanent suture rather than PDS suture, you just have to tie a loop in the PDS, put your Ethibond suture in, and just replace it. It takes about 10 seconds to do that. As you'll see, I'm replacing it right now. I pass a loop, pass it through, and now I've got a 2-0 at the bond suture in place, and I can tie it down. So it's a very, very inexpensive, very effective way to do suture repair in the anterior half of the meniscus that you can employ without spending a lot of money. One final thing that I do if I'm doing a meniscus repair in the absence of an ACL, I will do a microfracture in the intercondylar notch anterior to the ACL. So I will use my microfracture awl, and I will place 4 to 6 holes in the intercondylar notch to try to stimulate bleeding. And you will see that if you reduce your water and your pressure and turn the suction on, you can get pretty dramatic bleeding from these poke holes, which stimulates blood, helps the meniscus to repair. Does this work? I can tell you that it absolutely does if you're a goat. In this study, this is the only study I'm aware of looking at microfracture and healing, and in this goat model, they went from a 29% partially healed to 87% partially healed, and from 12% completely healed to 65% completely healed. So microfracture seems to provide a milieu for meniscus repair that certainly works in the animal model, and I think it works very effectively in the human setting as well. Thank you very, very much.
Thank you, Professor Robert Hunter. And now to the next speaker, Professor Charles Joseph, Modern Approach to Meniscal Injuries, Radial, Root, and Ramp Lesion.
While we change microphones, I appreciate everybody's patience for hanging in there late in the day. I'm going to try to build on a little bit of what Dr. was talking about, kind of give you just a little more, a few tips and some different thoughts and perspectives on that. These are my disclaimers, which are pretty clean on this. And so as Rob was mentioning earlier, really kind of more of a frame of thought. And so what are the current orthopedic trends that I see with regarding meniscus in North America? Really, is that we're trying to teach our residents and our young physicians that don't just take the damn thing out. You really want to do your best to try to repair the meniscus when possible. Now, our technical advances are actually making it a little bit easier to consider this. And then really there's developments on what to do maybe with in the meniscectomized knee. If we look at the trends that we're seeing nowadays, I think the numbers that I have looking at individual states, according, maybe a little bit different what Dr. Hunter noted, really about the ratio of meniscectomy to meniscal repair is about 16-to-1. With about 60% of those patients undergoing meniscal repair are generally males under the age of 25, and the vast majority of them are associated with ligament injuries. And we're trying to spin that a little bit to get that number to get up a little bit higher. Now, the reason being is if you fix a meniscus, what is the success in here? Now, we all understand that not all meniscus that we attempt to get to heal will heal, and actually, obviously, many won't. But the data will tell us that probably about 1 out of 10 will not heal and require secondary arthroscopy. So, I think the last thing I want to sort of get to is mention a little bit more about the root tears and ramp tears. I don't think Dr. Hunter covered that. And then I'll talk a little bit more about how meniscectomy itself in North America is actually under attack as maybe what would be considered a useless procedure by many. So certainly this is some more data, again, that meniscal repair in the state of New York. Again, 9,500 patients undergoing meniscal repair over the time study period, and only 9% of those patients required secondary procedures for removal. So I think that our surgeons are getting more educated about repairing meniscus, and we're seeing 90% success rates when that actually happens. Now here's why we make the attempt at repairing the meniscus. This is a nice study from Stein back in 2013, and they looked at patients who underwent knee surgery with a minimum of 9-year follow-up. And generally, the majority of these patients were anywhere from 12 to 15 years. And you saw that 81% of the patients who had a meniscal repair at the study time endpoint had normal radiographs, where only 40% of those patients who had a meniscectomy had normal radiographs, or the corollary, 60% of those patients had frank arthritic change by X-ray. So when you can make that decision to fix the meniscus, we think it's the right thing to do. Now, taking the meniscus out, and certainly in the presence of arthritis, is under severe attack. And I think the Arthroscopy Association of North America, together with many of our other professional societies, are trying to protect us, because we do believe that in patients, even with some low level of degree of arthritis, that there is significant benefit from arthroscopy and meniscectomy. You can see the study here, the quote in the New York Times, that the insurer spent $3 billion on a procedure that is considered to be no better than placebo. Now, certainly every orthopedic surgeon is going to say, we're going to take that as a personal affront, and it's our duty to really properly justify why we're considering surgical management in these patients, despite the, quote, early or even potentially moderate arthritis they have. Clearly, if they have significant osteoarthritis and their symptoms are not mechanical and their symptoms are primarily pain with significant radiographic changes, arthroscopic surgery is of no benefit. And these double-blind studies, of which there are several in the literature, this is from Italy. There was a second study coming from Western Ontario showing, again, there's no value beyond placebo value in this study group. So certainly you do have to pick your patients well. The other point that I do want to emphasize that Rob did a little bit was the meniscal root anatomy. And certainly that meniscus root itself is something we're seeing that may be the chicken and the egg effect on patients who develop osteoarthritis. And I'll show you some cases where it's quite dramatic and obvious. When we look at meniscal injuries and making the diagnosis, clearly history is important, but on physical finding, in my mind, there's only 3 points that really come into play, and it was borne out by Peter Fowler's study back in the late 1980s. Joint line tenderness, meniscal compression signs, which means load that particular compartment, and the presence of an effusion. I think those 3 factors alone really allow you to make that clinical diagnosis. Now, why not just jump to the MRI? We have patients all the time saying, "Doc, I got a sore knee, can I have my MRI?" And we always say no, because reason being, these are the same patient. This is a standing AP X-ray up on top. You can see what appears to be relatively normal joint spaces, normal contours of the bone. As soon as you flex that patient 45 degrees, turn them around and take a bent knee PA, you can see they've got near complete loss of their cartilage on the medial side. And I would venture to tell you right now that arthroscopy in this patient is of little of no value, and you should be considering more aggressive reconstructive options or palliative care with injections. So, is an MRI necessary? In North America, again, I think Dr. Tonino mentioned earlier about the litigation effects of North America. Yes, I can virtually tell you that every orthopedic surgeon, every orthopedic surgeon is now getting an MRI prior to surgical intervention, and not to make the obvious diagnosis like what we see here. When you have a locked knee with a locked bucket, I don't think you and I need an MRI to tell us that, but we really get an MRI for the other reasons, that zebra. Am I dealing with a patient that has avascular necrosis or bone marrow edema with a normal meniscus, or has a large focal chondral defect where the likelihood of my surgical intervention with a simple debridement meniscectomy is not likely to provide lasting benefit? So the MRI, in my mind, is used to rule out other conditions and really ensure the proper benefit of the meniscectomy. So here's a couple of examples. Professional athlete, 34-year-old, twisted knee, early season, bone marrow edema, MRI, or meniscus subluxed, significantly so. He's got flattening of the femoral condyle. He's had a radial meniscal tear for a while, so he was a professional athlete. We did a scope and clean out, and actually he did reasonably well and actually played another 4 years of professional ball before he was finally forced to retire over his knee. So here's another example. 38-year-old infielder, acute flare of knee pain and swelling after playing 5 consecutive days. He was old, no prior surgery, no clear-cut injury, but on his plain radiographs, which looked relatively clean, his MRI scan showed nothing more than large bone marrow edema in a very small medial meniscus. So at some point in the past, he had auto-meniscectomized himself and never had mechanical symptoms, and now is just having symptoms of bone overload. Again, surgical intervention in this case was not necessary. It would not be beneficial, and actually he was treated conservatively and did well and returned to play. So let's get to the actually acute indications for meniscal repair. Certainly, as Dr. Hunter mentioned, an acute tear, 1 to 4 centimeters, less than 6 weeks, vertical in the red zone or the vascular area, that's got the best chance of healing. Certainly a patient who's got normal mechanical alignment in concurrent ligament injury, those are really positive healing factors. So if you've got those entities, things are going to go well. Now, as Rob mentioned earlier, and this I want to show this, these are two different radial tears. And the old teaching, yeah, radial tears, they'll never heal, take them out. I can tell you right now, you don't take out that radial tear on that 18-year-old up top, that will be a degenerative knee before the age of 20. Whereas certainly the tear on the bottom, where it's a 55-year-old with a chronic root tear and already significant condylar wear or articular wear, really, there's no benefit to treatment in this case at all. So this is another patient, a 16 or 18-year-old with a chronic soccer injury 9 months prior, had a radial tear untreated to this point because he didn't report it, because he wanted to keep playing, and now he's got significant recurrent effusions, marked chondral thinning on both the tibial plateau and the femoral condyle. I went ahead and repaired this. It's late, and I got partial healing, but I think the slides that Dr. Hunter showed you earlier, this age group we're very aggressive with, and I would accept a 30 or even a 40% failure rate in my surgical treatment because I can at least save 60% of those 18-year-olds who've got a radial tear from having an arthritic knee by the time they're in their early 20s. So let's talk about the repair principles. Essentially, full assessment of the entire joint. I think that you should be putting the scope in the back of the knee on every single patient you look at. Every ligament you do, because I think you just need to get in that routine that arthroscopy should include posterior visualization of the posterior medial and posterior lateral compartment. Make sure that you've got a stable alignment. Now, the methods that Rob talked about earlier, all inside anchors, inside out sutures and combo, I think we ought to be facile with all of them. And I think all of us should have that ability to do the inside out because, yes, we can do much with anchors and implants these days, much more than we ever could before, but sometimes we forget. It's nothing. To me, this is just like doing that arthroscopic rotator cuff repair when times when the shoulder's swelling. Make an incision, make an incision, make an incision. I hate to pound on that, but make an incision sometimes. On the essentials, synovial abrasion, as Rob talked about, the microfracture of the femoral condyle. I think if you're doing a repair, that's a simple and automatic event. What I want to show here is just, in certain circumstances, I do believe that augmentation of this using fiber and clot is a very cheap and reasonable approach. Here we've got an intermeniscal signal change, a horizontal type cleavage, a very young patient, normal knee. This patient was 17 years old. Clearly, visually looking at the meniscus from the top and the back looks completely normal. There's nothing really there. But when you look at it on the undersurface, you can see there's an undersurface tear going up. It was an avascular area. This patient was treated conservatively. So I did a trephination. I poked a bunch of holes in it. But this is a young patient, an athlete. I was going to go the extra. So I harvested fiber and clot, 50 cc's of blood, spin it down, put the clot in the back of the knee, and then sandwich it in there with some sutures. I think my video may have locked up on me, so now that I've got Dr. Hunter disease, I think I'll move past that. Okay, now what about biologic augmentation with stem cells and PRP and everything? Really, our literature right now says there's no value. I think a lot of it we do it, and maybe some of you, and we do it in our professional athletes because we're trying to show the team owner, the general manager, the patient's player's agent that yes, we're doing everything. Do I have scientific rigor behind it? Absolutely not. So certainly we're hoping for more information. It's commonly used, but really of no clear value. Now, as I talked about before, I think that everybody needs to know how to do the inside out with an accessory incision. The pros, yes, this is how to get the solidest, most effective repair and the cheapest. It's the most cost effective as opposed to the implants. Certainly an implant can cost anywhere from $200 to $400, where these little double arm sutures are no more than $12 to $15. So the cons are it's labor intense. You need extra help. You're making an extra incision. It's time consuming. It's difficult. You can have complications. But you all should be ready. In my mind, I think you should practice this because really there's times when the anchors don't work. You've got to do that. And so you're going to put that meniscus back in place. You're going to freshen up the bed both on the peripheral side and on the central side. And then you're going to go ahead and pass some sutures in there and get a good repair. Again, these sutures are $12 to $20 a piece, and I think you should feel comfortable putting 8, 6, 8, 10, even 12. Now, you don't need to put 25 like Rob showed, but certainly it's something that I think we ought to be facile with. Rehabilitation of these patients, I do limit the range of motion to 90 degrees. I think that you load the meniscus in deep forms of heavy flexion, and so I'll hold off. I may allow them passive range of motion full, but never loaded beyond 90 degrees. And at 12 weeks, I'll let them start beginning increased activity, but I never let them return to sports after repair before 12 weeks. Let's talk real quickly about root tears. Certainly this is the one that we see the most of. Here's a case example, 40-year-old tennis player, squawking all the time with anterior knee pain. I got an MRI just to make sure there's nothing wrong. Unfortunately, she came back a year later, said, you know, she had severe knee pain, now swelling. I repeat the MRI, her meniscus is subluxed. The MRI shows a big root tear, and things are going bad. Now she talks me into waiting a little bit longer. It's 6 months before I finally scope her. Her root is now healed in an elongated position, and now it's unrepairable because she's got condylar change, articular thinning on both the tibia and the femur, and really she was beyond the point. And 2 years after surgery, she's got moderate to severe joint space narrowing. This is really a poor outcome in the long run. So we're becoming much more aggressive about these type of root tears. The old literature of leaving them alone, I think most of us are getting away from. Newer studies, including those popularized by Rob Laprade, have shown that fixing these, that generally anywhere from 60 to 80% of patients will have significant improvement. And as I show, the techniques are not that difficult. I think you do a relaxing or a pie crusting of the MCL, like Dr. Hunter showed. Using suture passing devices, you can pass multiple sutures into that meniscus, drill a plug right into that root, and as you're going to see here, that meniscus gets sucked right down into place. And if it heals properly, these patients, in my mind, do very well and are amongst the happiest. The key element is proper positioning of the root. And where you drill that tunnel, you need a guide, you need small drill holes, you need to have a small socket, but that's the key element. Here's a good example, a 20-year-old root tear, one you wouldn't think about, a PCL tear. The meniscus looks subluxed, yeah, but he's got a big MCL tear. Yeah, nothing worrying about that meniscus, but certainly I thought something was wacky. When I went inside, lo and behold, he avulsed the posterior medial root, and the meniscus is displaced. I made a posterior medial portal, went in, and you can see from the bottom, I was able to put stitches in there and properly reduce that root. And so I think in a young person, fixing the ligament and leaving that meniscus subluxed would doom this patient to essentially early arthrosis, and I believe that these patients are generally best fixed. So I think with that, I'll stop. I want to make sure we have time for others. The one thing I will want to say real briefly about is ramp tears, and my commercial on the ramp tears, always go to the back of the knee and look. And what you see, I showed that last slide, was what appeared to be a very normal meniscus up front. As soon as I put that scope in the back of the knee, can I just show 5 seconds? Can I have permission from our moderators?
Thank you.
2 slides,
Okay.
then I'll leave. So here again, you can see the top photos, the meniscus looks completely normal. Put the scope in the back of the knee and you can see a very large, complete meniscal capsular separation that the radiologist by that MRI actually missed. And so again, my commercial here, go to the back of the knee. In this case, I believe these are best repaired with a direct access using a suture passing device. I've got a cannula in the back of the knee using a suture passer and was able to get a good solid repair. Here's another example. MRI read as normal from a meniscus perspective. Visual appearance in the front is normal. Go to the back of the knee, something's funny. Make a posterior medial portal, and again, you see a complete peripheral capsular separation that warranted repair. With that, I'll stop. Thank you very much.
Thank you. Now the third speaker will be Professor Rahman Ganainy. He will speak about discoid meniscus, changing the concept.
Good afternoon. Discoid lateral meniscus. This is the outline of my lecture. Discoid meniscus is an interesting meniscal anomaly. It presents more commonly in the lateral compartment, but it can also occur medially. And there has been controversy in the literature, first described by Smiley in 1948. It described as persistent fetal stage of development, and in 1957 Kaplan described as to increased meniscal motion, and later it was suggested that it was familial transmission of the lesion. The exact epidemiology of prevalence unknown. Many are incidental finding and estimated to be present 0.4 to 16% of the world population, and much more common in lateral versus medial meniscus. Epidemiology. In addition, the high incidence of tear or degenerative changes observed among the menisci with discoid dysmorphy is almost double rate in comparison with the normal meniscus. In this study, evaluation of the morphological variation of the meniscus, they dissect more than 400 cadaveric knees, and they conclude the prevalence of total discoid lateral meniscus, complete or incomplete, was 30%. And also factors associated with bilateral discoid lateral meniscal tear in patients with symptomatic discoid lateral meniscus using MRI and X-ray. They found the incidence of bilateral discoid lateral meniscus is as high as 73% to 85%. The famous classification, Watanabe classification, complete type A, it fills the entire lateral compartment and it has normal peripheral attachment and is stable to probing. Type B incomplete does not fill the entire lateral compartment and normal peripheral attachment and is stable to probing. But in type C, it is more normal shape but lacks posterior meniscal attachment and has Riceberg ligament and hypermobile at posterior horn. The presentation of discoid lateral meniscus vary. According to type of meniscus, stable type may be asymptomatic and presence or absence of a tear. Also, it may be presented by snapping knee, classic presentation, more common in unstable variant, Riceberg. You can see or have audible or visible palpable clunk, popping sound as the knee moves from the extension to flexion. Imaging of the discoid meniscus, we do X-ray, normal X-ray, we find the fibula is high, more than enough. And also we find the lateral joint space is widened. And if you do tunnel view, you will find the hypoplasia of the lateral femoral condyle. This view is very important to diagnose the discoid lateral meniscus. Post-anterior view in 45 flexion with pairing radiograph, you can see the lateral widening of the lateral joint space and also squaring of the lateral femoral condyle and the cupping of the lateral tibial plateau. Also, there is very interesting sign, condylar cutoff sign. By tunnel view, you can see negative cutoff sign in the first sign, negative cutoff, as the arrow says, as arrow show, normal prominence of the lateral condyle adjacent to the intercondylar notch, but in positive sign, you see the decreased prominence of the lateral condyle adjacent to the intercondylar notch. And the arthroscopy was proven this. In MRI, it is the imaging of modality of choice suggesting discoid widths 3 or more contiguous 5 millimeter sagittal section show continuous of meniscus between anterior and posterior horn. Also in coronal view, you can see increased widths of the mid-anteroposterior diameter of the meniscus. Classification of discoid lateral meniscus by MRI on peripheral, based on peripheral detachment, we can see no shift. Number one, no shift. The peripheral portion of the discoid meniscus was not separated from the capsule, and so the entire meniscus was not displaced. Or you can see in sagittal view anterocentral shift, as the periphery of the posterior horn was detached also, and the entire meniscus was displaced anterocentrally. Also, you can see central shift. The whole meniscus will be present inside the center of the knee, or posterocentral shift as well. Treatment of discoid meniscus, number one, observation. Those discoid menisci found incidentally and asymptomatic, nothing to be done. But there is chance to surgical intervention. Can partial resection leave arms that can function adequately? So there is controversy how much you leave from the discoid meniscus after excision. And also some serious increase, says some increased thickness leads to recurrent tears and lead to further surgery. And so also how to manage asymptomatic unstable variant. So historically, they thought that abnormal, the discoid meniscus they do complete or subtotal meniscectomy because they say that will be maybe good function, but recently reattachment of the posterior meniscotibial attachment is widely accepted. When you do arthroscopy and to the video. You have to probe the posterior part of the meniscus. Usually you will find the posterior rim is displaced, and you may find a tear in the posterior part. And so you have to do suturization to reach and to leave a remnant of the meniscus. The difference to leave 8 millimeters or 6 millimeters, we will see. After you do suturization, you can find this tear, radial tear, and also you have posterior detachment of the tear. And then you have to reattach the posterior tear outside in suture, as you see. You close the radial tear, and then the posterior part you can take all inside by fast fix or some else. And so you can achieve good stabilization of the peripheral rim. What about the outcome? Arthroscopic treatment for symptomatic discoid meniscus in children, midterm outcome. This study was about 100 knees, and they underwent partial meniscectomy with or without suture repair. 13 underwent subtotal meniscectomy, and the Lesions score improved from a mean follow-up force to 4.7 years to 19. And they conclude that arthroscopic partial meniscectomy with stabilization of the unstable remnant, it was effective in preserving knee function with few early degenerative management. And also this study on long-term follow-up in children, about 10 years, also they do 3 groups, arthroscopic partial meniscectomy in 22 knees, and partial meniscectomy with repair, and subtotal meniscectomy. And also they conclude that arthroscopic reshaping for symptomatic discoid meniscus in children led to satisfactory clinical outcomes. But the subtotal meniscectomy group had significant increased degenerative changes compared with partial meniscectomy with or without repair. But what about risk factor for articular cartilage lesion in symptomatic discoid meniscus? Also this study conclude that the worst outcomes comes with symptomatic duration more than 6 months, if you leave it more than 6 months, and also for asymmetrical meniscal shape. Also this study about the arthroscopic meniscectomy for discoid meniscus to identify the width of the partial meniscectomy, the width of the rim, and also the reference of the new tears after meniscectomy. They retrospectively study about 46 children who underwent arthroscopic surgery for symptomatic discoid meniscus, all more than 15 years, and the mean follow-up was 31 months. The results, early results showed 3 re-tears when leaving 8 millimeter for complete discoid meniscus, and 10 about for partial meniscectomy. And they changed their technique to 6 millimeter for complete discoid meniscus and 8 for incomplete discoid meniscus. And so they found no re-tears. And so you can leave about 6 millimeter for the complete discoid meniscus and 8 millimeter for incomplete discoid meniscus. This study also about the prevalence of peripheral rim instability. They also retrospectively review about 112 patients underwent arthroscopic discoid meniscectomy, discoid lateral meniscus, and they have 62 complete and 37 incomplete. They found about 70% associated meniscal tear later on. And they conclude that peripheral rim instability was more common in complete versus incomplete discoid meniscus, and also in young patient more than older patient. Now for some technical aspect for surgery. If symptomatic, don't wait. So younger patient more likely to have better results as long-term follow-up. And also don't take more meniscus than you need. Because larger meniscectomy increase focal contact pressure and cartilage degeneration. And so osteoarthritis about 50%, 48% to 89% seen as long-term follow-up. Also, if you found softening of the central part of the discoid meniscus, it always have underlying tear upon suturization. Also, you can use an assisted portal under anterior horn of the lateral meniscus for the treatment of radial tear or tear of the discoid meniscus. This is assisted inferior anterolateral portal 1 to 1.5 centimeter lateral to the patella, to the patellar tendon, and 1 to 2 centimeter inferior to the anterolateral portal. MRI and arthroscopic correlation of discoid lateral meniscus. You may find double BCL sign on sagittal views MRI, but it not always indicating a bucket handle tear of the medial meniscus. As you see in this view, this coronal image showed discoid meniscus, and also the sagittal view showing double BCL sign. But when we do arthroscopy, you can see the giant discoid meniscus beside the notch, and so they give the false impression of double BCL sign. Riceberg variant of the discoid lateral meniscus with flipped meniscal fragment also can simulating the bucket handle tear by MRI. This view for this MRI for 9-year-old patient, boy with right knee locking and catching, the sagittal view showing absent posterior horn, and discoid meniscus tissue flipped adjacent to the ACL. Also this case, Riceberg variant of the discoid meniscus was flipped meniscal fragment simulating a bucket handle tear of the medial meniscus. Also this is a 9-year-old boy left knee locking and no trauma. He presented to you without trauma and may give the sign of bucket handle meniscus by double BCL sign. The sagittal 2M showing discoid lateral meniscus, and the coronal also showing medial displaced lateral meniscus tissue with cystic degeneration. And this is after doing a repair by arthroscopy. And so we can take home message. Number one, observe those discoids that are asymptomatic and found incidentally. Number two, if symptomatic, don't wait to operate. Younger patient, better results as long-term follow-up. And symptoms for more than 6 months associated with grade 3 to 4 cartilage lesions. So don't wait for more than this. Socialization and repair procedures for choice are of choice for if the tear pattern will allow. Don't take more meniscus than you need. Thank you.
Now, the last speaker will be Julio Fernandez, who will speak about meniscal transplantation.
So, I'm delighted to be here. Thank you for the invitation and some housekeeping announcements. No, I am not Vincenzo from Italy. He is stuck in Italy because of the coronavirus outbreak. So they called me in, the Canadian reinforcements, to give the lecture on meniscal transplantation. It's more of a technical presentation. Of course, we have some data. Yeah. So this. Oh, you gotta hold it. Okay. Are you sure? Doesn't seem to work. good. Got it. So nothing to disclose for this presentation. We've heard a lot about the meniscal sutures, meniscectomies. I think we're not going to go back into that. Basically, would say that, you know, almost 90% of these sutures will heal over time. We still have to discuss the unstable bucket handle there, but, you know, we had some great presentations on that. And meniscectomies, the point is that in the short term, they work. I mean, people have their meniscal tear taken out, and they don't come back. I mean, they're pain-free for 90% of the time. So you don't get them to actually to come back and discuss what to do when they lose more than 30% of their meniscus. Some of these folks who actually develop what we call post-meniscectomy syndrome, I mean, moderate to severe pain on the compartment, some knee effusion, sometimes even a daily knee effusion, catch and rubbing complaints. Bone edema, we've seen a couple of nice images about bone edema on the condyle. And some of these even develop a rapid onset chondrolysis with a very rapidly progressive OA in the months that follow this surgery. So for me, the ideal candidate is 18 to 50 years of age that's had a subtotal total meniscectomy, that has had surgery that with pain that's not subsiding after 6 months. It doesn't mean that we're not going to be proposing a meniscal transplantation to young folks that had subtotal or a total meniscectomy. It's just that they don't come to you so they can discuss the indications for it. You like that? Thank you very much. If you have, also you have to have a stable knee or have to correct the instability. You have to have an aligned knee or correct the malalignment. Grades 1s and 2s, even 3s, cartilage damage, they can be repaired. You can do it under the same procedure. So, like this patient of mine, 27 years of age, Royal Canadian Mounted Police officer. She's a CrossFit provincial champion. Had the medial compartment pain. She had a medial meniscectomy. 12 months before coming to see me, with pain that wouldn't let her do her professional activities, and she was unfit for her physical work. So what I do as a protocol for her is X-rays, AP, and PA with weight-bearing, inflection, lateral. I'll check the patella too, just make sure that you don't have a patellar problem, giving you a false pain symptoms. Check the axial alignment is important. Within 5 degrees of varus or valgus will be fine. MRIs and CT scans, X-rays, basically because we also have to measure the graft, so we have to send the information to the tissue bank for them to send us the correct sizing. These are frozen meniscus. They're non-irradiated. There's no cross-matching that's needed with this kind of procedure. And so, if you have that kind of knee, I mean, with a well-aligned knee, with no comorbidity, I mean, an isolated meniscal transplantation would be done. So, surgical technique, I use for the medial meniscus the bone plug technique. So, double bone plugs to get the roots back in place and get the tension hook back in time. Knees flexed on the table. You don't need tourniquets, no drains. I do use a posterior medial approach so that I can have some sutures on the back. So graft preparation. I mean, we get the block of the bone block with the meniscus. So the idea is to have these both these roots out with the block of bone. I change a bit the technique, so I use tight ropes to really to hold the roots, and I drive them through the tunnels, and then I can better control the tension on both roots for this procedure. So we have to see, you know, on the back. I have to be able to take a look at the knee. So you see, there's no more meniscus here. So he opens quite nicely, so I can really see on the back. We have to keep the capsule intact, avoid the meniscal extrusion the more we can. synovial debridement, if you have a hard time checking the insertion of the meniscus, you can do a small posterior notchplasty to see exactly where the insertion is. Pie crust in the medial collateral if necessary, of course. Then you drive your retro drilling and get your tunnel in. Now I know you have 3 images here, but the first up on the left is already the bone block going through the notch on the back of the knee. And then you have to push the meniscus on the back. There's a suture just pulling the meniscus in place, as you can see on the lower image. And then I have a 5 centimeter incision in the front, so I have a retro drill insertion of the anterior root, and I can slide it in, and then use a tightrope quote-unquote approach for that. So, and then sutures. I know we've seen suture techniques around here. So any sutures that will stabilize the knee, the meniscus. Usually 1 every 10 millimeters is more than enough. And that's what it should look like. I mean, it should look like a normal meniscus. Lateral meniscus is a little different because the horns are too close together, so both roots are too close together. So the dovetail technique with the bone block is what I use. Same procedure, put the knee on the table, 90 degrees, no tourniquet, you don't need that. Surgical approach as the posterolateral portal just for the sutures past the knee. You have to prepare the bone block, so actually we have this system for proprietary system for preparing the bone block, and it looks like this. I mean, you have the meniscus, you have usually it's a 30 to 35 millimeter long bone block, so it goes nicely into the plateau. Same thing. I mean, you see on the left that there's no more meniscus here, so we have just a little bit of the capsule to help us suturing the meniscus. And then we have to identify the position for this bone block. So right medial to the tibial spine, protecting the ACL, of course. And then you go through it, you rasp it, have your bone ready. As I said, 30 millimeters to 35 is more than enough to have this bone block in place. And then you pass your meniscus on the left for the sutures, and on the right, what seems to be a worm is actually the meniscus going in. You tap it in. I mean, I asked your fellow and explained that there's a 10-degree posterior slope so that he can tap it correctly once you got that. Do your sutures, and then actually you should have a meniscus that should look like a normal meniscus. So this is the lateral one. So technically, that's what it is. Some pitfalls. I mean, if you have your tunnels too parallel to the surface, you might just cut through the surface, which is bad. Too much tension on the root, and you cannot fix it on the capsule. Not enough. You're going to have a meniscal extrusion. On the lateral meniscus, if the bone slot is too lateral, and meniscal extrusion is something we have to be aware of. Results. So this is a 18-year-old girl that had a lateral meniscectomy after this discoid meniscal surgery. So meniscal transplantation 1 month after the procedure. She's doing fine. This man is 43. I mean, we had a medial meniscus allograft for him, so he's doing fine at 3 months. There's still a little bit of stiffness on the extension. And at 12 months, he came back for control. He's doing great. So he got all full range of motion, weight bearing, and no complaints. So if you look at that meta-analysis on the result for meniscal transplantation, the complication rate is fairly high, 26%, but failures are low, 9%. So discussing meniscal suturing, discussing meniscal transplantation, just about the same failure rate. Well, what is this complication rate? I mean, you're talking about minor tears of the meniscus that needs to be operated upon, so partial meniscectomies. Total meniscectomies and revisions are the most dreadful ones. Revision allografts. Can you revise an allograft? Yes, you can. A nice paper by Brand Cole on that a couple of years ago. And then other common complications that we see in our kind of surgeries also. So meniscal allograft transplantations, they improve quality of life for the patient that is symptomatic. I mean, it will last for 7 to 14 years. Whenever Donk is going to be here today or tomorrow, and he's got a 20 plus years follow-up on meniscal transplantation. Definitely less pain and infusion. Survivorship of the meniscal transplantation is fairly good. Almost 3 out of 4 are fine at 10 years. So return to sports, 3 out of 4 will go back to sport even at the level that they had before. Only 1 in 4 will go 1 level down. Failure rates just about the same as the meniscal suturing. Reoperation procedures might need a resuturing or partial meniscectomies, which are something that we see with the meniscal suturing anyway. So treat the meniscal transplantation just as a normal meniscus. And our clinical case, I mean, that's the lady, the young woman that had this medial meniscal transplantation. So you look at the right of your screen, you're going to see the medial meniscal transplant right over there. And then you can see that the meniscus is fine. There's no extrusion. So she's doing fine. And although you tell your patient not to squat, not to force her meniscus, as soon as she was ready to go, actually she was on competition, not squatting as you can see, not weightlifting as you can see, so hopefully her meniscus will hold. And that's it. I cannot do that myself, can you imagine? Thank you very much, that's it.
Thank you, Julio. Now we open the floor for discussion. For the first paper by Robert Hunter, Meniscus Pathology. تفضل. المايك لو سمحت يا حسام.
Dr. Hunter, actually I have 2 questions. First one, do you allow immediate weight bearing after meniscal repair, or you delay it? The other one, after release of the medial meniscus, partial release of the medial collateral ligament, to widen the field. Do you use a bracing or immobilization for the MCL?
Yeah, 2 good questions. The post-op protocol for me depends on the meniscus. If this is a peripheral tear that you've repaired, a longitudinal peripheral tear, weight bearing should be okay with that because you're reducing the meniscus a little bit when you stand on it. So longitudinal peripheral tears, I allow weight bearing that's tolerated, but I block their motion 0 to 90 degrees so they don't roll back on the repaired meniscus as they flex their knee. If it's a radial tear, if it's a horizontal cleavage tear, then I keep them non-weight bearing for 6 weeks because my assumption is you stand on it, you're pushing it open. So on those more unstable tears, non-weight bearing 6 weeks, range of motion 0 to 90. At 6 weeks, I allow the full range of motion, but there's no loading of the knee beyond 90 degrees of flexion for a minimum of 12 weeks and sometimes as long as 6 months, where I don't let them flex past 90 with load. The second question about the MCL relaxing procedure, the interesting thing is that this horrified me a few times I did it because I did it by mistake. And I put them in braces and I told them that I'd hurt their knee and I felt terrible about it. But it turns out that most people can't even feel that you've done that. They don't even know. And so I do not brace them. If they need anything, it's just a simple neoprene sleeve for a little compression. But I rehab them exactly the same as if I had not done the relaxing procedure. So I treat them with benign neglect.
Any other questions?
Rob, so a lot of these, when you do inside-out repairs, some studies have shown that you're very close to the neurovascular structures when you put the devices from inside towards the back of the knee. Do you do anything specific as far as knee position when you're doing the repair to try and avoid, or what kind of tips do you have to try and avoid the neurovascular structures?
Yeah, that's really important. For me, if I'm in the back third of the meniscus, I'm doing all inside. For that very reason, I don't penetrate the meniscus, I don't retrieve sutures in the back. But if you're doing all inside, you have to be careful too, especially on the lateral side. The neurovascular bundle is just behind the posterior horn of the lateral meniscus. So if you're doing a lateral meniscus repair, you have to be very careful about how long your needle is, how much you're penetrating the meniscus before you deploy whatever you're deploying in an all-inside technique. I use the inside-out technique in the middle third. So if I'm in front of the popliteus tendon or in front of the posterior medial corner of the knee, then I go inside out because I can pass the needles without having to make an incision, and I can retrieve them subcutaneously without having to protect the neurovascular structures in the back of the knee. So the back third, all inside, middle third becomes inside out for the very reason that you suggested. For me, it's too dangerous.
For Chuck, Dr. Bush-Joseph. So meniscal root tears, many times, at least in my experience, the articular cartilage is very damaged on the femoral condyle. I know it's very straightforward in the younger patient, but when do you decide when to try to repair? Does the state of the articular cartilage of the femoral condyle affect whether you try to repair the meniscus or not?
That's the great question, and certainly that's actually the answer too. I mean, in my mind, if they've got normal articular cartilage despite their age, even if their age is in their 60s, 65, I would be very aggressive to fix it. And I think the example I showed in my presentation was significant articular wear, almost near grade 3, if not some small areas of exposed bone. It's way too late. The cat's out of the barn. And from a radiologic perspective, any squaring or adaptive changes on the femoral condyle means, again, this patient's had a sublux meniscus for a long time or extruded, and now the condyle has started to square off. That's a sign of bone remodeling. Again, there's no benefit to attempting surgery at that point.
Okay. Thank you. There is a Formatsu classification for the chronic, for the root tear. Early, subacute, and chronic, or acute, subacute, and chronic. Before 1 month, it is so acute. 1 to 3 months, it is chronic, subacute, and more than 3 months is chronic. And after 3 months, there is no way for repair, and the valgus high tibial osteotomy will be the rule.
Dr. Arcadi, I would agree with that, although I would say that Rob Laprade has been demonstrating some techniques where he goes in, and I've done it on a couple of cases where I've done a posterior capsular release with a posterior medial portal to essentially almost free up the posterior medial meniscus off of the capsule, and he's shown that he can actually retranslate that meniscus back into place. I've done it on 2 occasions, but have no follow-up to support its benefit. But generally, my approach is similar to yours. Again, that acute, that 1 to 3 months, and then chronic. But I would still say that if the patient's got normal articular cartilage or near normal, I'm still going to be very aggressive and take a shot.
I have one question for you, please. Occasionally, we get this relatively young patient with a very degenerate signal on the MRI that is not reaching the articular surface. It's no tear. And you showed using the platelet, the fibrin clot, or can we provide him with some kind of biologic treatment? Can we inject something inside the meniscus? Does this work? Is there any research about it?
You know, certainly the slides I showed, unfortunately, I apologize that my video froze up. In that case, if there's nothing there at all visually on both the femoral and tibial surface of the meniscus, I merely just do a repeated trephination with a needle. But in the case I showed, there was indeed a tear on the tibial side of the meniscus, and so I went ahead and trephinated and then put in my fibrin clot and then just put a couple of suture anchors over the top of it. So I guess, no, there's no literature right now to support taking any PRP or any other stem cell and directing it into the meniscus itself. Certainly, I'm sure many people are thinking about it and trying to get some evidence, but there's no evidence really to support that. So I guess I do what maybe all of us do, just poke a bunch of holes and hope it bleeds.
Use microfracture when you do meniscal repair.
Yeah, I think that, like Dr. Hunter, I think in my mind that's such a simple thing to do to induce a bone marrow hemarthrosis. So yes, I think anytime you're trying to get tissue to heal where the vascular status of the tissue is in question, you want to take all simple measures to sort of enhance that.
Professor Ayman?
One more question, and perhaps you can elaborate more on this. You said that you have a different approach if there is a generated compartment, but you didn't tell us what is the different approach that you would follow. If you get someone with a varus knee, still in his 40s, with a root tear and some fibrillation of the medial femoral condyle as well as the tibial plateau.
Well, I think I talked a little bit about the failed ACL, and I don't want to steal the thunder of Dr. Hunter tomorrow, but that patient who is significantly symptomatic, and as I showed in my talk yesterday, have developed bone marrow edema lesions on the MRI, they're heading to an osteotomy or a unicompartmental arthroplasty. And yes, I'm going to do a lot of palliative care. I believe, and I'm not sure what your experiences are, you know, in the degenerative knee, that's mild to moderate in nature, the symptomatic, my results with viscosupplementation is about 70%. And I have at least 10, 15 patients in my head right now that come in to see me with the intent of getting an osteotomy. They've had failed repeated arthroscopies that I've palliated them for 6, 8, 10 years with viscosupplement. They show up every 6 months in a day, but it's covered by insurance. Medicare, our government insurance, still carries it. And yes, and as I also said, I don't want to, Rob's probably going to talk about it again, I'm a big believer in unloader braces. I think unloader braces work, and it allows patients to get that transition of how their leg would feel if we do an osteotomy to them.
Okay, any other questions for the first two papers? Okay, any questions for the third paper by Professor Rahman Ganainy? Okay. Yeah.
The question is, if you talk about some rim instability on the periphery of the meniscus, so are you actually reattaching the capsule to the tibial onto the tibial rim?
Reattach what?
The capsule. I mean,
Yes.
Yes, you are.
Yes.
How do you do that?
Reattach the peripheral rim to the capsule, okay.
Yeah.
All inside suture.
I know, but the capsule, not the meniscus itself. I mean, sometimes the meniscus is extruding, and then the capsule is really, really loose. So even if you get the meniscus back in shape, it's still an extruded meniscus. So how do you bring it back in? Do you reattach capsule? It's something that we've seen in
You may
posterior root.
sometimes you may do some release, and you do some release, and to leave about 6 millimeter, and to try to do it if you can, but no way to reattach.
Okay.
Even you have to do all. It will come again to snapping knee.
Okay, thank you.
Okay,
If I may comment on this question that's being asked about the displaced or peripherally detached discoid meniscus. Usually it is related to the timing. So if it is a chronic tear, there is a slim chance that you would be able to reduce it fully back into position, particularly that the lateral capsule or the capsular attachment is already a very weak attachment. So the problem with these patients with chronic tears or peripherally detached discoid meniscus, that if they are left for some time or if they are chronic tears, having done the fenestration, you may not be able to reduce it back into position. And this is the problem with the chronicity. It's very important to catch them very early.
But it is the question is to leave it or to try to attach it.
Yeah, but
if you can, especially in young children,
you will always have
even like
yes.
more you can remove. But if
for a child with a
for
displaced, yeah, for a child with a
Have to do.
displaced or peripherally detached discoid meniscus, we would always think of the benefit of doubt, as we say. So we would give him the chance and take the risk, despite the fact that in some occasions you are not able to fully reduce the meniscus back into
Chronic
position.
case.
Any other questions? Now, the last paper by Professor Collier about transplantation of the meniscus.
No allograft.
Okay. Now we close the discussion, and thanks for the.
Can I just say a
Yeah,
word before we close? Dr. Fernandez, we are very thankful for your contribution. Dr. Fernandez's name is not in the program, and this talk, the surgeon who was going to give it has cancelled his attendance in the last minute. So Dr. Fernandez was here, and he kindly agreed to give the talk of the meniscus transplantation. So we are very thankful for your contribution.
Okay, thank you very much.
Yeah, last announcement, the workshop for the reverse shoulder replacement will be here in the lounge in front of the room for those who will attend this workshop. Huh?
Thank you.
ما زال the eye